So we about different cardiac tests, diagnostic tests, exams. What were some things that we talked about that you might see when it comes to the cardiac system for diagnostics? Troponins, okay? Troponin's a big one. What is that telling you when that's elevated? Muscle damage, right? Yeah. Releases when the heart has damage. And why is it having damage?
Lack of
Oxygen. Good. Okay. That's kind of the gold standard, right? Troponin. Some of the other ones like CKMB, myoglobin, right? That might be other ones that are checked out if there's some damage to the muscle. But troponin is more specific. All right, good. What other tests did we talk about? EKG. Okay, what's that going to tell you? Electrical activity of the heart. Good. What else? Echocardiogram. Okay, so an echo. Other different types of echoes.
Yes.
Okay, yeah, what's that? What's a TEE?
They look more like the back,
Okay.
right?
Trans esophageal, right? So we're going down into the esophagus, look at the back of the heart, right? It gives a better picture of the heart, shows the back of it. What's the other type of echo? Yeah. PTE, which is what? Transthoracic, right? So that is just we use the probe, the ultrasound, not not invasive at all. Okay. And then we talked about ejection fraction. That information is going to give us. What is that going to tell us? What is an ejection fraction? Yeah, the percentage of blood, right? That's pumped from that left ventricle. What was the normal? 55 to 70. Good. Okay. What else did we check? Did we assess or look at? What's a big one that we did with a diagnostic test? Invasive. Check can either be a diagnostic or an intervention. Yeah, cardiac catheterization, right? Okay, we talked about that. What else did we talk about? And then we talked about chronic stable angina. Okay, how to know a patient has chronic stable?
Results with rest.
Results with rest or nitro, right? Okay, is it predictable?
Yes.
Okay, what about unstable?
Not predictable.
Not predictable, doesn't get better with rest, might be new onset, usually lasts more than 30 minutes. Okay, STEMI versus NSTEMI.
ST elevation.
ST elevation, okay? What do you know about ST elevation with a STEMI? Is that good? What do we need to do? What is it telling me when I have ST elevation, a STEMI? What is that telling me? What information? Yeah, it's an MI. Why is it an MI?
It's a complete blockage.
Complete blockage, right? Complete blockage. So what do we have to do?
Wow.
Blockbusters or cath lab? Yeah, what can we do in the cath lab?
Stents.
Stent, angioplasty and stent, good. Okay, what might you notice in an NSTEMI? ST depression or T-wave inversion. Okay, what is that telling you? Ischemia, what does that mean? Lack of oxygen. Okay, good. Does a STEMI have to automatically go to the cath lab?
No.
No, right? There's not it's not 100% blocked, right? We might just do meds, continue to assess. Okay, good. All right, good job. All right. So this is where we stopped last week. So we're going to look at some complications, right? After a patient has an MI or complication of an MI, there are some things that you might encounter, the patient might encounter. We're going to talk about dysrhythmias. That'll be the next section that we go through. We'll talk about heart failure, right? Left versus right heart failure, signs and symptoms, treatment. What do you know about cardiogenic shock? You'll talk a lot more about shock in CHOP 2 next term. But what do you think about cardiogenic shock? What do you think that is?
Is that like just the generic forms of shocks? Like
It's a form of shock. Yep, it's a form of shock. There's anaphylactic, hypovolemic. This is cardiogenic. What do you think it has to do with?
Heart can't pump enough blood.
Yeah, the heart can't pump enough blood, right? So it's a direct problem with the failure of the heart to pump, right? It's a failure, a pump failure. Which, could that happen after an MI? Yeah, why could that happen?
Because
Damage to the organ.
Damage to the tissue, right? We could have some scarring. What happens to our heart if it starts to scar? Doesn't pump as well, right? Okay, so cardiogenic can be something that can happen. When that heart muscle is unhealthy, right? So the pumping is not gonna be effective. If you think about it, what do you think your cardiac output is gonna be if the heart is unhealthy? It's gonna be decreased. Right? We're not as much blood is being pumped throughout the body. What's gonna happen to our MAP? It's gonna decrease, right? It's gonna be lower. Right? Think about that patient who is in cardiogenic shock, who has poor cardiac output. What are they gonna look like? Yeah. Hypotension, tachycardia, weak pulses. Keep going, Amanda. Cool, clammy skin, cyanosis possibly, altered mental status, right? Think about that. Those are all the things you're gonna see. If we're not perfusing to the rest of the body, the patient is going to present with those symptoms. Very good. Okay, urine output is gonna be low, right? We can monitor that. Okay, so what do you think we're gonna do? If we're not perfusing like we should, what kind of intervention would you do? Oxygen, good. Vasopressors, good. What's that gonna do? Yeah, increase that blood pressure, like your dopamine. Yes, what else? Fluids, that's a big one. Fluids. Okay, if we're hypotensive, right, we're not perfusing, the heart's not pumping like it should. Good job. Another complication could be pericarditis. What is pericarditis? Inflammation of what? The pericardium. What is the pericardium? Yeah, the sac that's around that closes that heart, right? It can become, cause some inflammation. How does the patient feel when they have pericarditis? Yeah, chest pain. Okay. And it usually is increased when they breathe in, right? When they cough, when they swallow, they can have kind of that substernal chest pain. Okay. If you were to listen to their heart sounds, what might you notice? Yeah, pericardial friction rub. What does that sound like? Have you ever heard one?
I got to hear one at work.
Did
the
you?
other day.
Yeah, what did it sound like? Do you remember?
Oh
Hard to
goodness.
explain.
Yeah, but it was really loud on this
Really
patient.
loud.
Mhm.
Sometimes they say it's like almost like a grating sound, or if you think about leather, like kind of rubbing up against each other. Okay. Sometimes the heart sounds are also muffled, like they're hard to hear. How does the patient relieve some of that substernal chest pain? How do they position themselves? Yep, forward, right?
Mhm.
Leaning forward, right? Flat was not good, right? That causes a lot of pain. Yep, so good job, Austin. Like leaning forward. Good. Okay. So if we have an inflammation of something, what would be a treatment we could do?
Steroids.
Steroids would be one. The other one might be an NSAID, right, to help increase that inflammation. Good. Okay, so some complications there. All right, let's look at some of our arrhythmias or just arrhythmias that you're gonna see. So here is an electrocardiogram monitoring that you guys learned about in skills, right? Remember we talked about that isoelectric line, right? That is kind of that baseline. So anything above that, right, is positive. Anything below that is negative. So that number one, what is that? The P wave. Okay, when do we have P wave? Atrial, right? Atrial contraction, right? What should it look like? Yeah, rounded upright, right? That looks, this is normal, right? Okay. We have our QRS. What should our QRS look like? Number three. Tall and skinny, right? Tall and skinny. What's happening at QRS? Ventricular. Yeah, Yep, depolarization and contraction, okay? So that looks good, and then number 4 is what? What's number 4? That's our ST segment, right? So that's where we would look to see if we have any elevation or depression. Okay. What's number 5 then?
The T wave.
The T wave. Okay, T wave looks at what?
Ventricular
Repolarization, the resting of the ventricles, yep, and then again, it should be a positive deflection, round. Okay, so we talked about ischemia, what might you notice about the T wave and ischemia? Inverted, yep, good. Okay, so that could be an easy look at, right, you're looking at your P wave, right, should the P wave be before each QRS?
Yes.
Right, this is what normal is, right? Now remember in NCLEX, you are not gonna get calipers to measure, right? You don't have to measure anything. Okay, I know you guys practice that in skills, right? How to measure and check these. So the ones that we're gonna look at today are the ones you really need to memorize, right? When they ask you a rhythm strip, you have to just look at it and know what it is. Okay? And then we can also think about rhythm. Is it regular? How would you know if a rhythm is regular? Yeah, consistent, right? Is the distance between your QRS equal length? Right, so you can measure that out, yes? You take a piece of paper and measure out to see if it's a regular rhythm. What about your rate? What's a normal heart rate?
60 to 100.
60 to 100. Anything less than 60 is what?
Bradycardia,
Bradycardia. Anything greater than 100 is?
tachycardia.
Okay. How would I figure out the heart rate? Yep, how do you do it? Count the what? The QRS is when? 6-second strip, right? You're doing a 6-second strip, you count the number of QRSs and do what with that number? Multiply it by 10. That's your estimated heart rate. Okay, so an easy way you can figure out, is it a regular rhythm? What is my heart rate? Okay. All right. Is this a lethal rhythm?
Yes.
Okay, what is happening here? Yes, the ventricles are doing this, right? Fib. Is it pumping? Do
Mm-mm.
you have a pulse?
No.
No. What are you gonna do? Defib, right? Defib. If I don't have a defibrillator with me right now, what am I gonna do?
CPR.
CPR, okay? Defib, right? Defibrillation is gonna be your best, or is your best intervention for this one, right? So this is a very disorganized rhythm. It's an emergency. There's no cardiac output. There is no pulse. Okay, could this happen after an MI? Yeah. It can happen with changes in your electrolytes, like a low potassium, low magnesium that we talked about, trauma. Okay, so what are we gonna do? We're gonna defibrillate the patient. Okay, so in the hospital setting, right, do you know where your defibrillator is at clinical? Yeah, it's on the crash cart. Where's the crash cart? There's a station, right? Or wherever you work, right? You should know where that crash cart is.
Mhm.
Okay, so tell me about defibrillation. What is that going to do?
Shocks the heart.
Okay, it's gonna shock the heart, and what are we trying to do?
Reset the rhythm.
Yeah, reset that rhythm, right? Hopefully make that SA node take over, right? Have a normal heart rate. Okay. Anything special you need to do here?
Clear before you.
Yeah, clear before you shock, right? Let's not shock everybody else that's around you, right? We're gonna shock that patient, and what are we gonna do immediately after we shock them? Please just start CPR, right? We wanna get CPR going, okay? Check for your pulse, start for CPR. How does that differ than what we have here? How is it different? Automatic external defibrillator.
That just has prompts you follow.
That's
Mhm.
prompts that you follow, right? You guys have all been trained on this because you have all gone through CPR. Yes, you'll see this at Walmart, right? You'll see this out in the hallways. Right? Any place that you go, church, right? They're gonna have an AED. What do you have to do here?
Turn it on.
Turn it on first,
Put your pads
put
on.
your pads on, plug them in, put them on. Now, while this is happening.
You're doing CPR.
CPR is going on, right? I'm doing CPR, Courtney comes over, puts on the patches, and then follow the prompts, right? It's gonna tell you, analyzing. Should you be doing CPR when it's analyzing? No, right? Hands off, it analyzes, then what does it tell you to do? Either shock or continue CPR, right? Okay. Good.
The AED is just the type of-
It's just a type of defibrillator, it's just, it's out in the community, right? You guys have all learned how to use one of those. Yeah. So those are more the sticky pads, or as in, you may see the paddles, you may see pads, depending on, where you are, right? Talking on patient, right? So you will go through ACLS, Advanced Cardiac Life Support, right? You'll go how to do this for a patient, how to give meds, how to defibrillate, how to do this. So, VFib, defib, yep, okay. All right, what do we got going on here? Ventricular tachycardia. What do you notice about this rhythm?
Went so fast.
It's really fast, yeah. Yeah. What's taking over? The
Ventricles.
Right, the ventricles are kind of pacing that. Okay, very fast. Can this patient have a pulse and be okay?
Yes.
Okay. Could this patient be pulseless?
Yes.
Yes. Okay, so I see this or any rhythm strip. I'm at the nurse's station and the alarm goes off and I see this rhythm or any other rhythm that's abnormal. What is the first thing you're gonna do?
Check the patient.
Check your patient, right? This patient could just be getting up to the bathroom and it might look all weird, right? And you're like, oh my gosh, the patient's in VFib. You know, call 911. But if it's in the hospital, you shouldn't call 911, right? You should call, you are 911, right? But you go in there, right? Check the patient. Okay? This case, right, we go in, patient's like, hi, what's going on, right? They might be talking to you and they're fine, okay? Can this rhythm go in and out? Could you have
Yeah, yes.
Mm-hmm.
maybe a 6-second run of VTAC and then the patient goes back to normal? Okay. What could be a side effect or a problem if a patient is in a fast heart rate like this?
Shortness of breath.
Okay, shortness of breath. Why are they short of breath?
So-
Oxygen isn't going through.
The competency for whatever activity.
Think about if your heart is beating really fast. Is it gonna be able to fill
Mm-mm.
and pump as much blood as it should? Okay, so over time, patients could have some signs and symptoms of decreased cardiac output, right? So the heart rate, you know, is in the high 100s here, 150, 160, 180. Okay. Again, can happen after an MI, changes in electrolytes, heart failure. Okay, so you might have a patient who kind of goes in and out of this rhythm. Okay. What would be some interventions we can do?
Amiodarone.
Okay, amiodarone, yep. Amiodarone is one of our anti-arrhythmic medications. Absolutely. Anything else we could do for this client? Okay, cardioversion. Yep, we could do a cardioversion as long as they have a pulse. We'll do cardioversion. If there is no pulse, defibrillation. Okay, so if they have a pulse in this rhythm, you could do a synchronized cardioversion. If they do not have a pulse, we would do defibrillation. Okay. Sometimes patients who are in this rhythm will also have to have an ICD placed, and we'll talk about that here shortly. But anybody know what ICD stands for?
Something inside.
Internal cardioversion, cardioversion or cardioverter defibrillator, right? So in place, so internally placed, so that the body realizes I'm in a lethal rhythm. What's it gonna do? It's gonna shock and hopefully put you back into a normal rhythm. Okay? So I'm gonna assess my patient. Right? If they're stable and they have a pulse and we're not coming out of that rhythm, maybe with medications, we can do a cardioversion. Okay? A cardioversion is also used a lot of times for atrial fibrillation. Okay? Tell me what you know about atrial fibrillation. This is that rhythm right here.
Regular.
Yep, irregularly irregular. Okay. Remember with atrial fibrillation, the atria are fibbing, right? They're not pumping as well. Okay, they're still pumping, but not as well. They're kind of quivering. So a cardioversion could be used for VTAC, it could be used for atrial fibrillation. And this just shows you that we're shocking that patient and hopefully go back into a normal heart rhythm. How does cardioversion differ than defibrillation? Okay, we're still hooking them up to patches, right? Same way we would for defibrillator. We have the same machine, but what's different? What's different? What is that arrow pointing to?
Syncing.
The sync button, right? So when you're doing a cardioversion, you have to have the sync button on. Because what is it gonna do? Yeah, it's gonna sync with the pulse, with the heart, right? So it should give that client a shock on the R wave. If we don't sync it and we give them a shock, we could put them into another even worse lethal rhythm like VFib. Okay, so let's not do that. So we will sync. There's just a button. You click it and it turns green, right? And I know it's synced. And you can see it on the monitor too. It'll show you how it's synced because it'll have a little pacer there.
So when you press that button, what did you say it shocks specifically?
Doesn't shock
R wave.
anything, it just is a sync button. It just syncs with the heart. So it looks at the heart and it syncs with that. That needs to be on for cardioversion. Then you would hit the shock button. Yeah. Okay, but it needs to be synchronized. Okay, so it's gonna shock them on the R wave. When you push the shock, it's gonna wait till it hits on the R wave and then it'll shock them. Okay. Again, hopefully to restore normal conduction through the heart. Okay. Let's talk about AFib though. Because cardioversion can be an emergency type of intervention we could do, or a patient could come in and have a cardioversion as an outpatient procedure. Okay, so let's say your patient had AFib and they went into that rhythm. They don't know when they went into that rhythm. Okay, but they're having some problems with it. So the doctor said, we tried medications, it hasn't worked. Let's try cardioversion. Okay, what do you think we have to worry about if a patient has been in atrial fibrillation for a couple days, couple weeks? The pooled blood. Yeah, so we have pooled blood that can happen in the atria, right? If the atria aren't contracting, we have that pooling of the blood in the atria. If we shock them, that clot could go into the body, right? Cause further issues like a stroke. Okay? So patients might be on an anticoagulation medication for a couple weeks to prevent that clot from. So we might put them on warfarin. Okay. How would I know that warfarin is therapeutic? Yeah, I would check my INR. And what should my INR be? What would be a therapeutic INR? 2 to 3. Yep, usually 2 to 3 is therapeutic. What does that mean, therapeutic?
Right, like pigment.
So, right, a normal INR is about 1, right? If I check my INR right now, it'll be around 1. Okay, if I would be taking warfarin, my INR would be therapeutic 2 to 3. So my blood is still clotting, right? It's just taking longer. So I need to check that iron, make sure that I'm therapeutic before we would do that cardioversion. Patients, if we're doing an elective one, right, anesthesia is there, they give them a little sedative. Sometimes respiratory therapy is there, give them some oxygen. Okay. It can be painful, right? We're shocking them. All right, what's the difference between cardioversion and defibrillation?
Syncs with the body.
So we're thinking, right, with cardioversion, okay? Patient who has VFib, how are we treating them? VTAC, ventricular tachycardia with a pulse? Cardioversion?
Cardiovert.
VTAC without a pulse?
Defib.
Defibrillation, good. All right. an example of the implantable cardioverter defibrillator. Okay, so a patient has had multiple episodes of possibly VTAC, right? Sustained VTAC where it lasted a long time. Maybe they went into VFib in the past. Okay. The patient can have an implantable cardioverter defibrillator. So what does that do? It shocks them, right? If they would go into another lethal rhythm. When you guys go to cardiopulm next semester, sometimes they'll send patients home with a vest, like
Life vest.
the life vest. Yeah, it does the same thing, right? They wear it and it would shock them if they would go into a lethal rhythm. Only time they ever take it off is when they shower, bathe, and then it goes back on. Okay. So some things to think about when a patient first has one of these implanted. Okay, think about skin, right? Look for signs and symptoms of infection. Okay. Never want to wear real tight clothing. This goes for a pacemaker, implantable cardioverter, no tight clothing around it. What else were some other things that you read about?
In the area.
Can't clean the air with mild soap afterwards. Yeah, what else to treat or to protect this or take care of a ICD? What other information did you read about? Usually we want to wait, I think Stephanie Day said a couple weeks, right? We want to be moving our arm, but we don't want to be routinely moving it around because that can change the position of the ICD of the finger. Good. What else did you learn about? You have to stay away from microwaves. Strong magnets. Microwaves, like your everyday microwave is okay. Right, but anything strong generators. Right. What about how, airport security?
You have to tell them.
You need a card, right?
Mhm.
Right, you wanna stay away from airport security? Okay, so you go through, you get like long down, you have to go through that machine, see if you're carrying anything. Do you think you should have a medical alert bracelet on?
Yes.
Okay.
You don't wanna lift heavy things.
Okay, lift heavy things, yeah. What about driving? There might be some limitations on your driving, right? You don't wanna be driving and then all of a sudden you get shocked. And now you could be unconscious, now you're in a car, right? So there are some limitations, every state's a little bit different. But usually they might not let you drive for weeks or months if you've had an episode. Okay, so that might be something that you would have to get your patient about. No MRIs, obviously, right? So there are some education to go with, when a patient has one of these. All right. What do we got going on here? Sinus bradycardia. Okay, so let's look at this. Can we see a nice P wave that's positive? Is
Mhm.
that pure oxytocin?
Mhm.
How about our T wave?
Yeah.
And it's repeating. It looks pretty irregular, right? If we had to measure the distance between the our waves, it would look pretty normal.
Mhm.
Now, this is a 6-second stretch. So what's our heart rate?
40.
40, right? We have 4 QRSs, so we multiply that by 10, so we have 40. Okay? So sinus bradycardia. And so our heart rate is gonna be less than 60. Otherwise, everything else is normal. Okay? Who has sinus bradycardia?
Athletes.
Okay, athletes can have that. If you're a big runner, right, your heart rate might just be naturally slower. Okay, who else can have a heart rate less than 60? Okay, beta blockers is a big one. Any other meds that might decrease our heart rate? Okay, possibly opioids. Digoxin is another cardiac med that would decrease our heart rate. Any sign or any disease processes that we talked about last unit that might cause our heart rate to be low? Everything slows down. Yeah, hypothyroidism, that's a big one too that can cause that patient. Okay. So sometimes we want our heart rate less than 60. Okay. Right, some patients on beta blockers, between 50, around 50 is okay. right? When does it become a problem? Yeah, when a patient becomes symptomatic, then it's a problem. What would be some things you would see in a patient who is symptomatic? Hypotension, altered mental status, confusion, heart rate's low, you're gonna feel kind of tired. JDD? JDD for. I don't have any fluid overload. Does it say JDD in there? Your lower heart rate. All right, so maybe it's okay. Maybe it's not. Logan, what would be something we would do to treat it if it's not okay? Patient's not feeling well, not doing well with a heart rate of 50.
Well, if they're on any kind of medication, probably either adjust it or take them off.
Right, yep, so if they're on a beta blocker, are we giving them too much, right? Too much digoxin. Okay, maybe they're toxic, maybe they took too much. Okay, atropine. Is that a medication that's gonna speed up the heart? Yep, it's an anticholinergic. What does that mean? You can use it for other things. What's an anticholinergic? You have a patient end of life. You give them atropine, what's it do? Dry them up, right? Anticholinergic, dries up secretion. So this, in this case, it's gonna increase our heart rate. Okay, so we're gonna adjust, right, meds. We can give atropine. If they're really symptomatic, what would you really do? Might need a pace study, yeah? We'll talk about that next. Okay? So, continue to be symptomatic, maybe atropine isn't working. We can do transcutaneous pacing. What does that mean? Shayla, what does that mean when I say transcutaneous pacing?
On the, place on the skin.
Yeah. We've got pads on the skin, just like we did for defibrillation. And then what are we gonna do? We're gonna pace them, so it's set to pace. Can we adjust how fast the heart rate is?
Yes.
So we can give them a little shock, keep their heart going. Is this gonna be long-term?
Mm-mm.
No, we just wanna get our patient stabilized. Okay? If atropine doesn't work, we're pacing them transcutaneously externally. What would be the next step if those don't work?
Pacemaker.
Yeah, they might need an internal pacemaker, right? So we're placing that, right? Permanently, right? We need that heart rate for some reason, with age, damage to the heart. Okay, for some reason that heart rate is just not able to be high enough to increase perfusion and cardiac output. Okay? So again, it's implanted. Same kind of thing we talked about for ICD, right? Okay. Usually you can see a little bulge right underneath the clavicle there. So you notice that patient has a pacemaker. And watch for signs and symptoms of infection. We talked about lifting that arm. Avoid MRIs, magnets. Okay, I think it talked about like generators or like, what did it say? Something about a diesel engine or something. So think about a person who maybe does engine repair, right? It should be over that because that can demagnetize it. Okay, what do you think the patient should do every day? Checking for what? Their pulse, right? What is their pulse rate, right? Gonna be set. No tight clothing. Okay. If you have a patient who has a pacemaker, you might see pacemaker spikes. Okay, maybe you've seen these, or maybe you will see those if you're going to clinical. What does that pacemaker spike tell me? It's giving a stimulus, right? So you can see that pacemaker spike, an atrial pacing spike, right? So it's gonna give that heart a little jolt, right? And then what should happen? Either way, the atrium, right? Now we know the atria is contracting. Or it could have a pacemaker spike right before my ventricle or my QRS. And that's saying that it's giving us a little, right, jolt to that ventricle. Okay, so you'll see they're called pacemaker spikes, those little spikes right above, and it could be before the atria, before the ventricle, or it could be both, it depends on what type of pacemaker they have. Anybody seen these? Yep, okay. What could happen here, though, that I'm gonna show you, is a failure to capture. What do you think that means? I have it, look at that. I have a spike, and then I have a nice P wave, I have another spike, P wave, and now I have two spikes, and nothing's happening. Not working, right? The heart's not responding to it. Call that a failure to capture. Okay, we gotta maybe do some more investigation. Okay, why we're not having that pacemaker should be causing that atrial to contract. All right. You guys learned about all the different heart blocks, right? First degree, second degree, type 1, type 2. And there's like a little song. What's a little song about Mobitz and somebody else?
Like about.
Going back, yeah, I don't know what's that song. I want you guys to focus on and know your complete heart block 3rd degree, okay? I want you to review secondary heart blocks that won't be on the exam, okay? But I want you to know complete heart block 3rd degree. Tell me what's going on in 3rd degree heart block. Complete heart block, what does that mean? What's not communicating? Yeah, the atrial and ventricles, right? So we've got some contraction, the atria is contracting, but it's not getting down to the ventricles. Okay, some people call this type of heart block a bad divorce. Okay, atria, ventricles, they were once married, now they're not. They're divorced. And guess what? They're not listening to each other, right? So atria is doing its own thing, ventricles doing its own thing. What do you notice about it? Here we got P waves.
P waves
Are
are
they,
equal.
are they? We got a
No,
P wave here, we got one over here. Very chaotic, right? P waves don't add up to really anything, right? There's no rhythm to it. We have QRSs though. But what do you know about 3rd degree heart block? What is our rate gonna be? What do you notice on the rate right there? It's low. They're gonna be very bradycardic. Okay. When I worked in a small hospital and I saw this coming, guess what? Get out of here as fast, right? What do they need? Pacemaker. Yeah, they need to have a pacemaker placed. Okay, you don't want to see that because they can easily completely block and now they're in a standstill, right? Okay, so these patients don't respond to atropine, right? We talked about atropine for bradycardia. They don't respond to that atropine, they need a pacemaker, okay? So if I'm gonna fly them or if I'm gonna get them into the rig, what are we gonna have them hooked up to?
Telemetry. Pacemaker.
the
Pacing, yes, we're gonna pace them, right? Because most likely they're gonna feel tired, they're gonna feel weak, they're gonna feel crappy. Okay, so we could pace them, transcutaneous pace them until they got to the facility. Right, and then they have a pacemaker placed. And I have some other rhythms that we'll practice here and kind of go through and make sure that you are familiar with the rhythms here. So we'll talk about those a little bit later. We'll have an assignment for us to do. All right. Maybe they'll forget and not come. All right. All right. Our next thing that we're gonna talk about that could be a complication is heart failure. So I'm gonna pass out a sheet. I want you to fill in, what do you remember about left-sided heart failure versus right-sided heart failure, right? What might be the signs and symptoms that you notice? All right, so can you fill in, what do you remember about left-sided versus right-sided? You guys worked on this for, was it your check-in picture, your last week, your next week? All right, why don't we take a break? We'll come back at 9, no 1, 10 minutes, 9, 10. And then we'll get them set up and then we'll get going.
Right.